In this video, I'd like to revisit the Sgarbossa criteria and how you can apply it to a paced rhythm. So the example that I've got for us here today is obviously a paced rhythm, and one of the biggest clues to that is we've got these pacer spikes preceding each of these QRS complexes. I do recognize that there are some sinus speeds here as well, but it seems like the pacer has been timed to basically hit the ventricle shortly after this atrial activity occurs. So moving on with paced rhythms, remember that anytime you have like an abnormal depolarization phase, so a pacer spike, for instance, depolarizing the ventricles kind of all at once, the repolarization phase is going to be then altered. And as a consequence, you're going to get this discordant activity, which is normally considered to be normal in the setting of both the left bundle branch block as well as the paced rhythm. However, if we say have a patient who's complaining of chest pain and it looks like they're sweaty, diaphoretic, and basically have like I'm having a heart attack written over their forehead, we're going to get a 12 lead ECG and we're going to try to apply some of the skills that we have, apply the Sgarbossa criteria to see if there is evidence of acute coronary syndrome. And so, if you'll recall, the first of the Sgarbossa criteria, we're looking for concordant ST elevation in at least one lead, and it needs to be greater than or equal to 1 millimeter. And so that's going to be our first kind of finding that we're going to be hounding for when we're looking at this 12 lead ECG is that concordant ST elevation in at least one lead, and that ST elevation being at least 1 millimeter or greater in height. And so if we take a look in our kind of stepwise approach, we'll notice that in lead one, we do seem to have some concordant activity. Here's the pacer spike, here's the QRS complex, and here's the T wave. And we'll see that both the T wave and both the T wave right there and the QRS are all pointing in the same direction. And so we do have some concordance. As far as ST elevation is concerned, it's kind of difficult to tell, but it looks like we're really maybe pushing maybe a millimeter, maybe a half millimeter, but the quality is not so great. So we'll just keep that in the back of our head. Let's move down to lead two. We got this biphasic QRS, not really any sort of conclusive ST depression or elevation. Lead three, predominantly negative QRS, but no concordant ST elevation that we can see. And then AVR looks all right. AVL looks suspect. If we zoom in on that, we can see that we have a positive QRS complex and a positive T wave, and it does in fact appear that there is some slight elevation from the baseline. In fact, if we were to look at like the TP segment, so this segment right here, we can appreciate that there is some elevation. And again, it looks to be maybe about a half a millimeter to a millimeter, but the boxes are kind of difficult to look at. If we cycle this trip all the way back to V4 and V5, this is when we can really appreciate that concordant ST elevation. So V4, we've got a pacer spike at the beginning of the QRS complex here. And if you look at the relationship of the QRS complex, which is this structure, and compare it to the T wave, you will see that the J point is far and away above and elevated off of the isoelectric line. Furthermore, if you recall, there is something else here that suggests, or at least strongly suggests, MI, and that is the presence of a hyperacute T wave. In that this is the T wave, and it is pretty darn massive. And we're using massive as a relative term. It's going to be massive in relation to the QRS complex. If we can take this and fit it in there, that would define as a hyperacute T wave. So V4, we're done. This is positive for Sgarbossa criteria. We are definitely concerned about MI in this particular case based off of this complex. Now, just for funsies, we're going to look at the other complexes. We've got V5 and V6. If you zoom into V5, again, we see that the QRS complex and the ST segment, when the QRS complex terminates, the ST segment is well and above the isoelectric line. So there is some pretty clear elevation. So this again is specific for MI in a left bundle branch block, movement these, or paste rhythm, which is what this is. Um, and then again, for funsies, we're going to go through the other criteria just to see if we can knock it off. When it comes to the second criteria, we're looking for ST depression in these leads. So lead V1, lead V2, lead V3, that is concordant. If we do scrutinize these V leads, we can see that there really isn't any sort of concordant ST depression. So we can fairly confidently say that it does not fulfill Sgarbossa 2. And let's think about Sgarbossa number 3. Now, Sgarbossa number 3 is the less sensitive of the three criteria, and that is looking at the relationship of the ST elevation and how it compares to a QRS complex as far as the length is concerned. And so, if you recall, Sgarbossa 3 criteria requires that the ST elevation in a discordant lead is greater than or equal to 25% of the QRS complex. And if we take a look at some of these complexes, we can pretty quickly see that, yeah, it is in fact positive for three criteria in that we have a STA segment elevation, so this stuff right here, which is very clearly 25% or greater than the QRS complex below it. So this patient has an MI until proven otherwise. They have both Sgarbossa 1 and Sgarbossa 3 criteria